So those generally are sort of the big pieces that I look for. Can they afford it? What are the symptoms and side effects that they're going to get from the therapies? Can they report? And then actually, can they take the medicine reliably that it will not be more harmful to them?
On today's episode, ways to help patients adhere to oral anti-cancer regimens. What oncology teams need to know is next. Welcome to Cancer Buzz. I'm your host, Summer Johnson. Oral medications are one of the most important recent developments in oncology. Less invasive than IV infusions, able to be taken at home, they give patients more independence during their treatment. In 1998, the first oral anti-cancer medication was approved, and 20 years later, oral agents comprise an estimated 1/4 of all oncology agents in development. Although they reduce the patient's burden of care, self-administered medications bring new challenges. And without close management by the care team, issues like adherence and safety can arise, impacting patient outcomes. Successful patient care with oral anti-cancer medication is deliberate, with timely coordination among providers, pharmacists, dispensing pharmacies, and of course, educated patients. If it's not properly coordinated, prescribing oral oncolytics can compound some of the existing complications of cancer care that include poor patient understanding, high out-of-pocket costs, payer restrictions, and the intricacies of using external specialty pharmacies. Our guest today shares her pharmacy team's model to ensure successful use of these medications. Dr. Emily Hajjar is the program director of the Population Health Pharmacy Program and a professor at the Jefferson College of Pharmacy.
I've had many patients where they don't have a support system, they don't have any way to remember to take their meds, and giving an oral oncolytic is not an option. We either will take it as they see fit, or perhaps they'll overuse or underuse this medicine. And so we've had many decisions where we say, the patient is not adherent enough to therapy that we cannot give them an oral oncolytic. They need to be coming into our cancer centers for infusions. Now, that sets a whole nother host of issues, right? They have to have transportation, they have to get in for their chemotherapy. But sometimes, laying eyes on the patient much more frequently, as in when they come in for weekly infusions or a biweekly infusion, is much more beneficial versus giving somebody 30 days worth of meds, letting them go into their own space and using that as they say fit, right? We know that some patients, overuse, some patients underuse, but a lot of times, again, we really make that decision that sometimes they're not a candidate for oncolytic therapy, and they really need to have a more of a trusted system where they're getting IV infusional meds.
You mentioned adherence. Are there any more concerns or challenges that you find in oral oncolytics, such as side effect management, that sort of thing?
Oh, absolutely. So when we give an oral oncolytic, we need the patient to understand how to take them, right? So sometimes not only we give the oral oncolytic, but we have to give supportive medicine on top of that. So antiemetics, things to help them manage the symptoms and the side effects that they're going to get from the actual therapy. And one of the jobs that I also do when I really screen patients is to determine, can they self-report any adverse events? Do they have the cognitive abilities? And in the older adult realm, sometimes, patients do have a level of cognitive dysfunction that they can't self-report. And so if we're really going to rely on that, we really make sure, again, that patients not only can manage their own meds, they can tell us what side effects they have. Because as part of my job is we want to pick the meds that's the safest for them, right? So if I give an oral oncolytic and it makes them worse or perhaps tips them to the point where the harms are much more outweighing the benefits, that's not in anyone's best interest. So again, we really make sure that they can report how they're taking it, what side effects they're getting, and then also cost. So a lot of times, these agents are not inexpensive, and we have to make sure that we're having social work involved, our financial counselors, just to make sure that we are going through the right patient assistance programs, that we're not essentially, making them use up all of their monthly expenditures for this one medication, because they still need to have, money for transportation, for food, for housing, things like that. So those generally are sort of the big pieces that I look for. Can they afford it? What are the symptoms and side effects that they're going to get from the therapies? Can they report? And then actually, can they take the medicine reliably that it will not be more harmful to them?
You talked about cost and using your financial counselors. What's the difference with patient care and management of these regimens when they go to an external pharmacy versus using the in-house pharmacy?
So I think if you have an in-house pharmacy, it's a little bit easier to have those conversations, right? So one, when you have an in-house pharmacist that's specialized in, let's say, specialty oncology care, one, they generally know which patients are eligible for those medicines, right? So we know that those medicines have things like if it's a first line or a second line that they should be stepped through certain therapies. So the pharmacists know how to maintain or manage those prior authorization criteria to make sure that the patient is truly eligible for those meds. And then they can have a direct conversation with the patient about what is the expected cost. Now, I've seen where, you send somebody to an external site to say, hey, pick up this medicine. It was covered. They go pick it up, but yet the copay is $800. And it's just financially stifling for the patient that, again, that's the discounted price. So while it has been covered, that's still not affordable. And so the pharmacist, if it's right there, could have a very easy conversation with the patient to say, hey, this is what it is. Here's the copay. Can you address this? Is this financially viable for you? Or do we have to then look into other options for you right away? Now, if you send somebody to an external pharmacy, then they get the prescription price, and then they have to come back to the office. Then it's another prolonged process about what is the patient assistance program. So you're losing time.
What are the other benefits for patients of specialty pharmacies?
The other benefit of having a specialty pharmacy sort of right with you is the fact that pharmacists, one, again, can screen for adherence. They can do a lot of personalized patient counseling face-to-face with the patient and understand their other supportive meds that they're doing, again, just to make sure that they're going to take everything, right? So it's one thing to take the pill right, but then it's another thing to take the antiemetic at the proper time, and which antiemetic is used sort of a preventive measure, which one is used for more acute nausea. It's things like that. Or, do you have to take an aspirin every day? And just to make sure that they're fully, aware of the full spectrum of all the meds that they're taking for that specific condition. So that's kind of where I think the most benefit is to having a pharmacist or a pharmacy clinic that can dispense these medicines right with you, just because, again, you got that face-to-face, you're not relying on phone calls for patient counseling, and potentially you've got another expert resource right with you as that pharmacist that's embedded in your clinic.
Let's talk about medication adherence and the role that pharmacists play in that. Can you describe for us your operational workflow for patients who have oral medication regimens?
So first, when we're doing a screening just to see if they are eligible, we do a really in-depth medication history. So a lot of times people will pull up the list in the computer and say, oh, you're taking this medicine, right? And the patient, of course, wants to please their provider. So they say, uh-huh. And of course, they give a great report. What I tend to do is ask the patients to bring their medicines in with the actual pill bottles. I open the pill bottle, I pour a few pills in the cap, I show them to the patient. I ask them to identify, without showing them the bottle, what is this tablet? What do you take it for, and how do you take it during the day? Is it, one tablet twice a day? Is it one tablet once a day? So this very in-depth medication history before we even start any oncolytic therapy gives me a really good sense of their adherence to their other medicines on top of, right? So as a geriatric provider, patients come in with at least 10, 12 medicines, right? On a good day, I'll have somebody with 5 and they're like, I take so many meds. And I'm like, 5 meds is really, in the grand scheme of things, very low, right? We have people, 15, 20 meds. So with that, I do a screen to begin with. Okay. Then once we give the oral oncolytic, when they come back into the office, we double check again that they're taking it correctly. So how many times in the past 7 days have you missed this medicine? We ask the common side effects that we think the patient could be experiencing that could limit their ability. I ask them very specific times of the day. So they'll say, yeah, I take it once a day. And then I'll say, okay, well, what time? And they'll say, in the morning. And then I push it even further. I'm like, okay, what time is morning for you? And so I try to dig deep and get those very specific details.
What are some of the issues you discover when you do these screenings?
I've also seen where patients will tell me, I take it in the morning, and they'll have 5 meds that they'll take in the morning. And I'll discover that they take one at 9, one at 9:30, one at 10, one at 10:30, one at 11. And then they say to me, I can't do anything because I'm tied to my pill box the whole day. And I'm like, I understand why, if that's how you're taking your meds. Some people have a very big fear of taking more meds, like, numbers of pills at one time. And so by reassuring them that they could take multiple pills at one time with, let's say, 1 glass of water, so that, within a 10-minute period, all their pills are taken, that also frees them to be able to do their daily activities. They can leave the house, they can go see their grandkids. Well, if it's not the time of COVID, they could leave their house. But again, I find a lot of people are chained to their pill box, and that's not necessarily how anyone wants to live their life. So that's a little bit of my workflow of how specific I like to get just to make sure that I truly am addressing their adherence. A medicine reconciliation where you're just like, yep, you still on that? Yep, you still on it. And you don't really dig deep. Of course, a lot of patients are just going to tell you what you want to hear.
How do you approach patient education when it comes to oral anti-cancer medications?
Absolutely. So one, explaining why they're taking the medicine is a big deal. So a lot of times patients will say, or they'll lump all their meds, right? Oh, those are my cancer pills. And they don't realize that one is fighting the cancer. One is giving them some nausea relief. One is for if they have pain. So it's really kind of splitting those all out, not to say these are my cancer meds as a lump sum, but this is what this one does. This is what this one does. I then even go a little bit further to then explain to them what time of day, if they need to take it with food, if they can take it on an empty stomach, and again, why, right? So a lot of times people will say, well, I have to take it on an empty stomach, or I have to take it with a full meal. And you then get into the explanation of, well, if you don't take it with that meal, you won't absorb as much medicine. It's not going to be as beneficial to you. Or if you take this medicine on an empty stomach, you're going to get an upset stomach. So really explaining to them the reason behind why they have to take it like they do that. And then, of course, really kind of explaining to them how important it is to take on an everyday basis, right? So there are certain meds that if you're feeling horrible and you've been vomiting incessantly, that you could potentially not take that day. But then there's other meds that you really have to make sure that you get a few crackers in, you take this medicine and you continue on with that. So again, I really try to make sure that they know all the reasons behind that. And then I tell them some of the expected side effects, right? What are common things, right? So I think a lot of times patients will read the information or totally not read it, right? And they have no idea, is this medicine causing this side effect or not? And again, that just helps me on the back end when they come back into clinic for that next review. Remember we talked about this one can cause nausea. Are you having any of that? Or this medicine might cause some joint aches. Are you having any of those types of things? And so it's really kind of explaining that up front. And then that really makes them be a little bit more watchful for those side effects that I'm hopeful that they can report. And again, that's a lot of what I do educationally for those patients.
What does follow-up then look like for the patient?
So a follow-up would be where, again, we just reassess sort of the meds. Now, I like to be comprehensive when I see them, but sometimes you just don't have the time, right? So normally on my first visit, I look at, all their antihypertensives, their cholesterol meds for, any condition. On follow-up, we really kind of just look to see, all right, you have a lot of pain. Tell me how you're taking your pain medicines. This is your oral oncolytic, right? One, tell me how you're taking it, right? It's always open-ended questions. You never say to somebody, are you taking this? Yes, no, because that gives them such an easy out to do. So really using those open-ended questions to say to me, tell me how you're taking this. A lot of times people will say, well, I intend to take it at this time of day, but you know what? Sometimes I just don't get around to it till 2 hours later. And you'll say, okay, well, that's totally fine. You got it in within that time period. Then I ask the common symptoms or side effects of those medicines that they may be having. So again, I really focus on adherence and then those self-reported outcomes. And then, of course, any monitoring that would then accompany the medicine that we would have taken with regard to, laboratory work and things like that.
Do you have a standard plan that you follow when it comes to follow-up and patient communication?
So in the senior adult oncology, we're a lot of a consult clinic. So unfortunately, I don't get to see many patients back. However, in my supportive care role, I often see patients from both clinics. And in that time period, we're really focusing on their symptoms. So things like pain and nausea. And so we do have prescribed time periods, whether it be every 2 weeks or every 4 weeks that we see them. And again, even though I see them in a different clinic, I then still really make sure that they're taking their oral oncolytic the prescribed way it is. And oftentimes I'll find that perhaps they've self-DC'd, and then I make sure that that communication goes back to the primary oncology team just to let them know. So just because I don't see them back sort of as a follow-up in my senior adult oncology clinic does not mean that I don't try to communicate with their primary oncology team to make sure that everybody's aware of their adherence.
How does that communication go with other team members on a cancer care team? Is it on a case-by-case basis? Is it structured? Is it through the EHR?
Yeah, so every time I see a patient, I put a very detailed medication history into my notes. So that's always in there. So as part of our initial consult in the senior adult oncology clinic, I have a very detailed note. And I actually have a clinic partner that's another pharmacist, and we have a standardized template that we want to make sure that we're addressing things like allergies, things like, what are their meds? What does their adherence look like? Do we have any specific counseling points for them? So we make sure that we put that in as an initial note. And then every time I see somebody back or any of my other notes, I put a very standardized also medication history in my notes. And then I go above and beyond too if I need to communicate back with that. Now that's a little bit more of a case-by-case basis. So if everything's going well, I just enter my note just like a normal sort of visit. But if there's any alterations where they have self-DC'd any therapy, I make sure that I contact that primary team just to make sure that they know that the patient is no longer taking something that they were prescribed to. And again, that is through the HR, but oftentimes too, it's nice when, you work amongst people and you can have a personalized conversation. But if that's not the case, I always make sure that I message through the system just to make sure that it's been documented, and then they can do a personalized patient outreach on their end.
What do we need to know about the next generation of pharmacists? How are they learning about oral anti-cancer medications in school?
When you're in pharmacy school, right, you get to the oncology block and it's usually later in the curriculum because it tends to be pretty difficult topics and very detail oriented, right? So generally, you get that a little bit later. So you walk in as a pharmacy student, you know how to treat hypertension, you can treat diabetes, and now cancer is like this big sort of scary thing, right? One, you don't want to get it yourself, and two, gosh, those medicines are really toxic. So I think since I've been in pharmacy school and how we've kind of taught it to students is not necessarily, do you need to know as a general practitioner of like, okay, somebody has breast cancer, knowing the first line drug, right? That can be overwhelming because the literature changes by the day. So how we've kind of reformulated the teaching of sort of oncology topics is that supportive care role, right? It's if somebody's on this drug, how do we help support the patient the best? Or if they're on an oral oncolytic, here are the things we need to make sure. Again, can they self-report outcomes? What are we going to do for them with adherence, right? Here's the big ones that cause nausea. Here's how we treat nausea. So it's become a little bit more of a, not that rote memorization of, okay, what's the first line drug for prostate cancer if it's stage 3, right? Or if you have a metastatic melanoma, right? How does that change? So that used to be sort of the fear of all pharmacists. But now, since we really approach it from a supportive care role, and that, listen, you may not necessarily be the one to choose the therapy, but if a physician says, like, this is the treatment plan, here's how you can help support that patient. And yes, I think everyone is very interested to be able to have that ability to help support the patients at any one time.
The need for specialization is obviously growing. How do we reach pharmacists to specialize in oncology?
In the world of pharmacy, residencies are optional for us, right? So we don't have to have that postgraduate training. There's very few oncology residencies, right? And if you're lucky enough to get one and specialize in that, of course, you know all that stuff by heart. So I'm going to tell you, a majority of the pharmacists are not oncology trained, as I'm not, right? I'm geriatrics trained. So with that being said, to get people that have this interest, right, and that can work on that supportive care role, especially in this new realm of specialty pharmacy where those oral oncolytics are being dispensed out of, having patients interact with those people to know, very rote things about adherence, right? So pharmacists get excited when they can help somebody, right? So they'll say things like, I'm not an oncology pharmacist, but I really helped this patient remember to take them. I set up a medication calendar, or I suggested a really cool way to remember a telephone timer on their phone that rings at a certain time or rings multiple times a day. When pharmacists have that ability to do that, yes, they are much more invested. They are much more eager to participate. And I see this with students, right? So students are so much more tech savvy than I ever was, right? So they know the latest app on their phone, right? So they'll say things like, oh, Dr. Hajjar, did you see this wonderful thing that they can go in and check a box every time they take a medicine? Or they'll create these elaborate calendars for them. Well, they'll put a pill, on a piece of paper, they'll tape it, and, the patient's able to put a check mark every time that they've taken that this week. So the students are, one, super creative. They're generally more on top of technology, perhaps, than I am, just because since I'm not a techie person. But I will say that pharmacy students, when they can get in and they know that they're impacting patient care, again, that energy and enthusiasm grows. And again, that's kind of what I love to see as a provider, is to say, okay, now you've got that spark. All right, continue your studies. Let's go on. Let's become a specialist. And then you can continue to champion this movement going forward. But anytime that you can notice your impact on a single patient, it just gives you so much more energy and excitement that just sometimes for that other patient that really frustrates you, it's that other one that you succeeded that, wow, you're going to continue on. You're going to try for that next person.
How are you coaching pharmacy students to communicate with patients about medication adherence? It sounds like they are already being really creative.
So I get a lot of the students that are in their experientials, right? So first of all, when I'm in the classroom, right, the best thing you can always encourage students with is patient stories. So that's why I love being a clinician and getting to go into the classroom, because when you use somebody else's words or you give a personalized story, they then take note and they listen, right? So if you're just reading out of the textbook, you're going to lose them, but those patient stories really bring them in. And so then when I get them in the clinic, and my students all come through my senior adult oncology clinic, I let them take the reins, right? So they watch me for a little bit and then they get my style and then they put their style. So the things we always, ask the students to do is meet the patient where they are, right? So one, never be condescending. If somebody is having trouble, that's wonderful that you got somebody to be honest with you. So it's through that sense of rapport, making the patient feel comfortable, using patient-centered language, using open-ended questions, and then being really just matter of fact about it. So adherence escapes a lot of us, right? And so when you take medicines multiple times a day, it can be hard, and not everybody loves medicines like pharmacy, right? So I think a lot of people assume pharmacists love to take more meds and more meds and more meds, but in my perfect world, patients wouldn't be on medicines, right? So that's the safest way to be, is on the least meds possible. So I get my students to really take a non-judgmental approach and just to make it okay, normalize it for the patients. This is hard. You don't feel well. You have a very serious illness. And when they can make those connections and express that empathy, and patients are more honest with them, then we get the best clinical picture that we can, and we can put the best services in to help support that patient. And so that's what I really try to say to students, is to say, one, they're not a patient, they're a person. And it's not I have a checklist, I'm going to ask all these questions. It's you're having a conversation with another human being and get them to open up as much as possible. And then you've done your job. So I really try to take away the medicine piece and put the humanization piece back in.
You can find more information on managing oral anti-cancer treatments in the show notes. Thank you for supporting Cancer Buzz. We hope you're enjoying the show, and we would love it if you would leave us a rating and a review. You can also share the episode with a colleague. Ratings, reviews, and referrals help us continue to bring you the latest trends and resources in oncology care. Next time on Cancer Buzz, cultural humility and sensitivity in oncology. Until then, for the entire Cancer Buzz team, I'm Summer Johnson.
Cancer Buzz is a resource of the Association of Community Cancer Centers.